types. There's hyperactive, hypoactive, and mixed, which is just a combination of the two. So hyperactive is patients with this subtype are restless, agitated, hyper alert, often psychotic, like it is a symptom, delusions and hallucinations, and can be aggressive. We want to obviously stay away from those terms, which is a handout sheet, so it's not using person-centered language. But we want to make sure we are staying away from things like aggressive, agitated, and psychotic, but that is not for there's hypoactive. So people with this subtype feel lethargic, drowsy, sluggish, apathic, respond slowly to questions, have decreased spontaneous movement, and seem sedated. And then there's mixed, which is just a combination of the two. So there are some core features of delirium based on the DSM-5, so disturbance of consciousness, changes in cognition, and disturbance that develops over a short period of time. So it's usually that acute onset we'll see. It's not something that, will take 5-6 days to slowly progress over time. It's something that you're going to see very rapid changes, and there's sometimes fluctuations throughout the day as well. Some interventions that we can use to prevent delirium. I know these are small. I'm happy to send you the link after to the charge nurse email. And it has this as a handout. It's a 2-page it's long, but it's 2 sections. So you can avoid or discontinue inappropriate or unnecessary medications. Use standardized and safe approaches to control pain. You can do things like increased hydration, reduce likelihood of transition. So, for example, of course, if you have to send a resident out, you have to send a resident out. But if they get transitioned from unit to unit, floor to floor, here to there, they're in and out of hospital a lot, for example, that can increase the risk of delirium. Medication changes, of course, things like infection, dehydration as well. Ensuring adequate nutritional intake, promoting, like I said, with dehydration, reorientation and or cognitively stimulating activities, and identifying needs for sensory aids. One of the most commonly used screening tools is the CAM, the Confusion Assessment Method. They don't jump on that. There's no point to be looking. No, if they jump, then there's a screen. No, they will not put it in between. There is an opening. Yeah, just maybe go get. I don't understand this one. Oh no, they don't jump. Don't worry. You will take good care. Is there? That's okay. 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 So delirium, the most acute of the 3 Ds, delirium accounts for 10 to 15% of admissions to acute care hospitals. According to one recent estimate, 10 to 30% of hospitalized patients aged 65 and older have an episode of delirium during their stay. That's a large amount. Typically, the patient is oriented to person, but not to time or place. Their thought process is disorganized, and they lack the ability to shift focus, sustain attention, or cooperate with caregivers. That ability is greatly impaired. Their speech may be loud, argumentative, or difficult to follow or understand. They may have altered perceptions, including visual illusions, hallucinations, and that may lead them to misinterpret their environment. For example, they may feel threatened by shadows on the wall. Considering delirium an emergency, you have to consider it an emergency. The difference, for example, between delirium and psychosis is usually treated by antipsychotics and isn't necessarily an acute onset, whereas delirium is. Delirium has medical underlying factors. So you would get it, things like we said, maybe a medication change, urinary tract infections, other types of infections, dehydration, inadequate nutrition, things like that. So it has a medical underlying cause. Whereas in most times psychosis has psychotic, like the need for antipsychotics and a break in reality. You want to consider it a medical emergency that requires immediate attention because it is something that can be resolved, and if it's left untreated, then it is something that can lead to death. One of the things you also want to just keep in the back of your mind, I heard this, I was in a presentation the other day, like I was listening in on it, and somebody said that apparently the PSWs know typically up to 3 days prior to an official delirium diagnosis, not that it's a full diagnosis, but a temporary one. PSWs know up to 3 days before the resident is officially diagnosed because your residents that well. Like you see those changes, you see those signs and the symptoms, and obviously getting the official diagnosis for delirium from, like, for example, urine or blood work can take a while to process and come back. Compared to just sending them out to the hospital, for example. So often these things well before they're even happening. Here are some differential diagnoses and potential causes. The cat's inside, and do you want me to shut the door?
It's okay.
Okay. So potential causes are infections, withdrawal, like from alcohol or medications, acute metabolic, like acidosis or electrolyte disturbances, any trauma, so like head injuries, falls, for example, CNS disease, like hemorrhages, cerebrovascular accidents, hypoxia, so like loss of oxygen, chronic lung disease, deficiencies, environmental factors like hypo or hyperthermia, diabetes, acute vascular like hypertensive emergency, subarachnoid hemorrhage, toxins or drugs, and heavy metals. These are just some of the potential causes. On to depression. It is a broad diagnosis in which low mood and or loss of interest or pleasure in most activities are key features. Other symptoms can include irritability, anxiety, social withdrawal, pain, fatigue, reduced or altered sleep, and appetite, feelings of guilt or worthlessness, reduced self-esteem and confidence. There's a high risk of suicide among older people with depression. Older adults typically experience a series of losses. So as we know with older adults, the loss of their house sometimes, right? Like they're coming here, they're losing their place of living. Sometimes they lose their spouse, not even just their spouse dying, but they're moving away from the spouse, so they no longer live with them. Or their family moves away, their friends pass away. They're losing financial freedom because now maybe, hello, kitty kitty. Thanks, but no thanks. So, no, you went 2 slides ahead. Also, I think you peed because I think you got me a little wet.
That's white.
Pardon?
This one.
Okay.
Hand white. There is beside you.
I have a pet. I'm not even worried about it. It's fine. Not on me. I think she might have peed like maybe somewhere else and then her private, so just
And the bone.
so anyways, I'll hold on to that for now. Yeah, so there's a lot of losses that are associated with aging. And because of these losses, many people wrongly, thank you for this, by the way, wrongly assume that sadness is an inevitable consequence of aging, but instead of an extreme prolonged sadness should be recognized as a possible warning sign of depression and a treatable cause at any age. So this isn't an exhaustive list, but these are just some things that we can look for in the older adults that we serve if we're ever wondering what could it look like. Because in older adults, depression can look different than in adults of our age, or people in like high school, younger kids, people in their early 20s, for example, as well. So for example, one of the things you may see is like psychosomatic symptoms with your older adults. So they may have pain with no known or treatable cause. Like they may say, oh, my elbow hurts, and they have no reason at all for their elbow to be hurting. And so you want to look at how depression may present differently in the older adults that we serve, because it may not be our typical symptoms like, well, I don't want to go outside today, I don't want to eat, I don't want to do this. It could be that, but there's also other signs and symptoms that may be associated with the aging population. So we want to consider things like, not answering the phone or the door. If your residents have access to that, sometimes they may, for example, have their own phone in their room. Expressing feelings of worthlessness and sadness, unusual outbursts of crying, agitation, or anger, or showing little emotion. Spending more time alone. Maybe they're discussing suicide, but it might not be outwardly suicide. It might not be like, I want to kill myself. They might say things like, I don't want to be here anymore. Like, I'm not happy here. I would rather not be here. And those are times where we want to question what that means, right? Because that could be anything. I say I don't want to be here all the time, but I just want to be in Europe. Like, I'm trying to go on vacation. So you want to always inquire that with your residents too, just about things like, what does that mean? What is not being here? Where would you rather be? Just to talk more about that with them. So what are some strategies we could use to assist an older adult who is experiencing depression? You can think both pharmacologically and non-pharmacologically. What are some ways you could support your residents? Pardon? Try to make them busy with certain things.
Yeah.
Okay. Yeah. Yep.
Maybe activity that will engage them.
Yeah.
To overcome their loneliness.
Yeah, okay, great. What would an example of an activity like that be?
Like, usually I saw some of my residents, they are so sad,
Mhm.
and some music or some like programs that they wanted to watch, and then they feel like they're
Amazing, yeah. And it's important what you both said about ones that mean something to them and ones that they like, because we can't, you know, if we're not personalizing it, then it won't do anything. Like if we just sit them in front of a TV and turn on any station, any music, then that probably isn't helping compared to if we say, oh, they really like the platters, they really like, you know, who's the guy that sings, put your head on my shoulders, that guy, right? They might like him. And so you gotta personalize our approaches to make sure it's something that is meaningful to the resident you're engaging. Okay, so how do we approach depression? You might be wondering. Things like being active, right? Of course, that will look different in our older adults. It's not going to be, you know, running around, going outside, going to the gym, but things like chair yoga, Zumba, ball tops, physiotherapy, right? Things that can still keep them active and moving. If they are ambulatory, walking around the unit, if they can go off the unit, maybe seeing if you like take them outside of the back, of the front, things like that. Getting so if you have a psychiatrist, a psychologist, or a geriatrician on site, getting the appropriate assessments. If you have a VSOT or a GMOT team, getting the appropriate team members and appropriate supports for that residence as well. Think positively. I do want to preface, not hate, that's a strong word, my dad always said. I don't like when people say think positive when it comes to things like depression, because if that was quick fix for anybody who's ever had depression, we would not be, a lot of us would not be in service and working. So I want to reframe the words think positive, the like sentence think positively. I want you to look at it more as cognitively restructuring your residents' thought process. I know that seems like a huge task. It's not. What I'm trying to say is in situations where they maybe have depression and they may say, oh, I just, you know, I don't even look good. I don't even want to go outside today. I don't want anyone to see me like this. You can start pointing out, like, didn't you get 2 compliments yesterday from 2 other residents? You look really nice. You know, this color really brings out your eyes or your hair. Or if they say, I just feel so lazy today. I'm like, who likes a lazy person? But you did so well this week. You came to 3 activities. That's 2 more than last week, right? And just helping them see the positive. So I would never say tell your residents to think positive, because hey, if it was easy to get rid of depression by just thinking positive, I think the pharmaceutical industry would be not in business as strongly as they are now. So just kind of restructuring their mindset around things, pointing out the positives, the good that they're doing, right? Reframing the way they think about their environment. Does that make sense? Eating well, of course. Yeah, go ahead.
When I took some courses about social work, they tell me like to think about what we have
Yes.
instead of thinking what we lose. So we can tell, oh, look
Great.
what you have.
Gratitude.
Look what you have in your room. Oh, you have an album. So
Let's
let's talk about your memories. And
Yes. Great, exactly. Yeah.
we focus in what they have currently have.
current and experience.
Good times too, remembering happier days, right?
Yeah, usually like one of the residents there, when I go, because I know she has a difficult resident. So I always ask, oh, this is my beautiful music teacher. I always remind her that she was a teacher before, even though I didn't, I don't know what being a music teacher before. At least you acknowledge what she had before.
I think that's great with the right resident, right?
Yeah.
Sometimes reminiscing
Yeah.
what they had could make them sad. Also, are you excited? Sorry, side note. I see you have the Ovo shirt on. Are you excited for Drake's new album, Iceman?
No. No, my husband was the one who was trying to solve it.
But no, even yes, picking and choosing who we do reminiscing with, because sometimes reminiscing can also be like, well, that's not what I have now, and I'm sad to realize all they've lost. But yes, reminiscing is also a fantastic, well-researched tool with your residents too. Getting involved, right? So that could look different person to person. Maybe that's having a conversation, reminiscing, connecting them with their family, connecting them with maybe day programs or external resources that could be of benefit. Managing their stress could be deep breathing. It could be, like you said, practicing gratitude, mindfulness, meditation. Of course, avoiding alcohol and oh yes, about eating well. We know with a balanced, and I'm not saying diet, I'm not saying to tell your residents to go on a diet, but we know that with certain foods come certain feelings in the sense, if you eat a well-balanced diet, then you feel better, right? Physically, emotionally, you feel better compared to if you had McDonald's for breakfast, lunch, and dinner, it's naturally going to make your body more tired. Right? Like foods like that make you sleepy, they make you feel bloated, they may bring down your mood compared to foods that have a lot of like vitamins and things that boost your body's like immunity and mood. And spirituality, if it's appropriate for them. So depression can affect anyone at any age, but is often not recognized in older adults. This is because some signs of depression can be mistaken for signs of aging, and also because older adults who are depressed may not complain about feeling low. When left untreated, depression may continue for weeks, months, or even years, and untreated depression is the main cause of suicide in older adults. So we're dealing with a generation, right? Or sometimes not just a generation, but a culture that may have not openly expressed mental health concerns. They may never, a lot of the times, the generation that we're working with, it was all like hush hush, don't be dramatic, everybody's going through that, you're like, keep it to yourself, don't talk about those things. It was a sign of weakness, right? And so we want to keep that in mind. You may not hear your residents necessarily express like, oh, I'm depressed, I feel worthless, I feel useless. It might be just in their behavior that we're seeing this. And so we have to look out for both the verbal communication signs and the nonverbal signs that they may be experiencing this. So this is very small. I will zoom in. We're not going to go through the whole assessment. This is something called the geriatric depression scale in a short form. So there's a bunch of questions. You can see that it's highlighted, like no is highlighted, it's bold, rather yes is bold on some of them as well. And this is just to show, it kind of summarizes here, like if it's a score of 5 points or more, it can be suggestive of depression. 10 points or more, it's almost always suggestive of depression, and 5 points, warrant a follow-up and a comprehensive assessment as well. So pretty much anything over 5 to 10 points is indicative of depression. This isn't a sole assessment that can determine depression, of course. It's not to say you fill this out, the resident automatically has depression. You would want to do those further inquiries and follow-ups because there could be other reasons for these moves as well, right? Are they experiencing a loss? Did they just move in? Is there a medication change? There's of course other reasons that these feelings could be present. So that's why it says like more of a comprehensive assessment to kind of get to the bottom of it and treat it. Okay, dementia is a term for a group of conditions that cause a decline in the brain function and difficulty with skills such as memory and attention, orientation, time, and place in person, language, reasoning, and judgment, regulating emotions, and processing information. So with dementia, there are about 100 types of dementia, or over 100 types of dementia. These are some of the most common ones that we hear most often or most frequently though. So we have Alzheimer's disease with the greatest prevalence, 60 to 70%. We have some key characteristics here, like active and tangled, impairments in memory, language, and visual spatial skills. Vascular dementia, which is 10 to 20%. You may see impaired motor skills and judgment. Frontal temporal, which is about 10% of dementia cases. You may see personality changes and in issues with language. Lewy body, which is about 5% of dementia cases. You may see hallucinations, disorders, sleep, impaired thinking, and motor skills. And there's other dementias which account for about 5% of the cases. For example, those related to Parkinson's, Huntington's, Creutzfeldt-Jakob, and Korsakoff's. Korsakoff is alcohol-related dementia. When we are looking at dementia, I could do a whole presentation on everything to do with dementia, but I obviously had to include 3 diagnoses in the span of 30 minutes. So I tried to make a little highlight reel for everybody. You want to consider that all behavior has meaning. If you go on the Brain Exchange website, I know I've talked about it before, clues, causes, and considerations is a great way. It does pieces assessments for every single behavior. You can also look on the Brain Exchange website at the meaningful engagement tool. That could be very helpful for the team. Look for ways to meaningfully engage a resident, different adaptations for like visual, hearing, sensory impairments, etc. You want to always take a trauma-informed care approach with your residents. Doesn't matter if you know if they have trauma or not. We always want to assume that our aging population has had some encounter with trauma in their life, and having a trauma-informed care approach won't do any harm to them. So even if you use all the trauma-informed care strategies and they don't have trauma, there's literally going to be no harm in doing so. Focusing on one's needs, interests, skills, and abilities, which is a dementia care approach. That's pretty, what are their needs? What are their unmet needs, right? They need for belonging, need for attachment, need for, feeling purposeful, feeling needed, feeling wanted, feeling tired, feeling helpful and useful. You can do this by using a leisure and health assessment from Dementiability. So I included a link. Again, I'm happy to send that over to the nursing team or whatever one you have access to on site. If you have a leisure and ability assessment that you use, for example, on PCC, this is just extra supportive documentation. If you want to use it, it is online and available. You can do this use the one that you have currently in practice. You can always look at Keep Us Snow's YouTube videos. I know I've showed you some before in the past, so that's also something you can consider. And referring to previous trainings offered. So if we've done GPA, if you've done pieces, Dementiability, you first, for example, you can always refer to your other trainings on how to support people with dementia as well. Here's just a chart. We're almost done, like 2 more slides. So we're still at 5 minutes, so we're good. So kind of the highlights on what's the difference between delirium, dementia, and depression. Delirium is acute. Dementia is insidious, months to years, and depression is acute or insidious months. Delirium is fluctuating, dementia progressive, depression may be chronic. It goes through the duration, consciousness state, attention, psychomotor changes, and reversibility. So we have a quick case study. So Mr. A is an 82-year-old resident living in long-term care with vascular dementia. In the late afternoon, he's often seen walking through the hallway and expressing concern about getting back to work. During this time, he may appear worried, unsettled, or less receptive to care approaches. Through conversation with family, staff learned that Mr. A worked for many years as a school custodian and handyman, enjoyed repairing tools and organizing supplies, values being helpful and having responsibility, lives with benign prostatic hyperplasia, BPH, type 2 diabetes, depression, and vision impairment. He responds best to simple instruction and familiar routine. The nurse and PSW want to support Mr. A using a meaningful non-pharmacological approach that promotes purpose, comfort, and engagement. So, which intervention best reflects a person-centered meaningful engagement strategy based on the resident's needs, interests, skills, and abilities? Can everybody read that okay?
Sorry.
Pardon? I'll give you a moment to read over that, and then I want you to tell me what your answer is. And if you can't read it, I'm happy to zoom in or move this.
Leave a slide.
Pardon?
Leave a slide.
Oh, sorry. Okay, yeah, no problem.
B. Answer.
Oh. Do you want me to go back to the answers? Or?
Yeah, the answers.
Okay. So what do you think the answer is? A, B, C, or D?
Maybe B.
B. Anyone say another answer? Or we're all thinking B? B?
B.
Okay, B is the correct answer, yes. Invite Mr. A to assist with the familiar helper roles such as sorting large stools, organizing safe maintenance items, or helping staff prepare supplies for the evening shift using simple one-step queuing and adequate lighting and his glasses. Why do we think that's the best answer?
That way he can correlate the previous work and this work.
Yeah, exactly.
He likes to do that also. Yeah.
And what are we also considering based on his skills and his abilities? What do you think he has if we need adequate lighting and glasses? Does that signal a hearing impairment? What does that signal that he might have?
Yeah.
A vision impairment? If you need glasses and you need adequate lighting, right? That would be a vision impairment. Yeah. Okay, that's it. Does anybody have any questions, comments, or concerns with that? No? Okay, thank you so much. Have a wonderful day. Have a wonderful day.
Thank you.
Thank you. See you.
I love.
See you again at 3:15.
Yeah.
No, it's like the